That's a really good question. I would say it's challenging for sure. Right. So first of all, you gotta look at is this a does the patient have an indication for this medication? Yeah, right. So possibly they are. So you can have a patient who has insomnia or just trouble sleeping because they're elderly and have other comorbidities. So you can potentially have a patient who's on SSRI for tazapine. Uh, for like sleep and for mood or depression. And then you also see potentially there are like trazodone, PRN sleep, and a benzo PRN sleep. And so that's kind of like multiple drugs that are not particularly great for an elderly patient that can increase the risk for falls and everything. And so you kind of have to assess the situation, right? Are they taking the mirtazapine? Maybe it could come out that the patient actually wasn't really compliant with tazapine, and they're just more reliant on the trazodone. As we know, antidepressants for sleep, you kind of have to start taking it. It takes about 2 weeks for it to kick in and have that effect, right? So reliably take that first, and then see if that improves before we kind of jump to the different other medications. And then having specific PRN indications is important, right? So if we're having that 3-drug regimen for tazapine, that should be every night at bedtime, regardless, right? Standing. And then you kind of choose like, okay, maybe trazodone is our first line. So PRN, sleep, not responding to tazapine. And then you have benzo as last line, not responsive to tazapine and trazodone. So you're kind of making different layers so that the patient doesn't get all 3 drugs at once. That's one thing, right? And then just having those conversations with the physician. Sometimes they may not be thinking about it because these are medications from home that they're just continuing while they're in the hospital. And you can kind of bring out like, hey, this patient actually came for a fall and that's why they fractured their hip. Should we discontinue some of these medications, right? So utilizing what else is going on with the patient to kind of reinforce your recommendation is beneficial. Sometimes it's just not something that's like on the forefront of the physician's mind because they're being admitted for a completely different issue. You notice polypharmacy for these other non-active issues.